với Huy lên đi. Đây ngồi đây. Đây này. Rồi. Thôi chúng ta bắt đầu cái phiên cuối cùng trong buổi chiều ngày hôm nay. Thì cái phiên đầu bắt đầu từ báo cáo đầu tiên của giáo sư Hideaki Sakata, khoa tai mũi họng Santaka của Viện Malaysia, với đề tài Curable congenital hearing loss, điếc bẩm sinh. Please, Professor.
Thank you, Chairperson, ladies and gentlemen. My name is Hideaki Sakata from Saitama Medical University in Japan, Kawagoe Institute. In 2010, we collaborate with Dr. Nam and his team from Hanoi University in Vietnam on newborn hearing screening. Today, I would like to talk about current situation of congenital hearing loss in Japan and what it means to cure sensory neural hearing loss. Today, I will be discussing several key topics. The current status of newborn hearing screening, NHS, the progress made in understanding causes of congenital hearing loss, accurate hearing assessment in children, treatment options for sensory neural hearing loss, curable forms of hearing loss, such as congenital cytomegalovirus infection and gene therapy, as well as the challenges we face in the future. This is a famous 1998 report by Yoshinaga Itano. Sorry. Yoshinaga Itano. The vertical axis represents the language index at the age of 3, while the horizontal axis indicates when the hearing loss was detected. As we can see from the results, there is a significant difference in language scores between the group whose hearing loss was detected before 6 months and the group whose hearing loss was detected after 6 months. In 1800, the wild boy of Aveyron was discovered at about 10 years old, and Ital attempted to teach him language. However, he never succeeded in speaking. In the 18th century, education for children with hearing loss was conducted solely through sign language. At that time, it was believed that children with hearing loss also had intellectual disabilities. In 1898, Alexander Graham Bell, the inventor of the telephone, visited Japan and advocated the education of children with hearing loss should include oral communications as well as sign language. Bell was convinced that Helen Keller could speak if properly educated, which is why he introduced her to Anne Sullivan in 1894. In Japan, special education for children with hearing loss began at the age of 3 in 1969, but early detection was difficult. In 1970, the discovery of the auditory brainstem response, ABR, occurred. And in 1999, automated ABR was introduced in Japan from US, making newborn hearing screening possible. Automated ABR and DPOA are simple and provide results within minutes, printing either pass or refer. In Japan, the screening rate was 72% in 2011 and has currently increased to 93%. In the United States, the screening rate had already reached 95.7% by 26. This slide illustrates the process of newborn hearing screening and the subsequent steps leading to special care. In the obstetrics department, automated ABR or DPOA is conducted. If the result is LIFA, ABR or ASSR, as well as cytomegalovirus testing are performed. If bilateral sensory neural hearing loss of 50 dB or greater is detected, early intervention and special care are initiated. This slide pertains to close examinations. Initially, an examination of the ear is conducted, followed by various tests. As necessary, genetic testing, CT and MRI scans are performed. From around 3 months of age, hearing tests such as BOA, COR, and VRA are conducted. Additionally, the cerebral cortex is examined using near-infrared spectroscopy. Here are the results and follow-up 67,368 newborn hearing screening cases. After NHS, 456 cases were referred for further testing. Subsequent detailed examinations identified 78 cases with bilateral hearing loss of 50 dB or greater, qualifying them early intervention. This slide shows the typical results of ABR test. ABR reflects frequencies from 3 kHz to 4 kHz, and we always perform a tone burst at 500 Hz to assess the low frequencies. Additionally, in children, it is often difficult to differentiate between conductive and sensory neural hearing loss. So, bone conduction ABR is also conducted. The limitations of ABR. While ABR can detect down to 20 dB, we often find low-frequency hearing loss when the child is old enough for audiometry. DPOA can perform frequency analysis, but it is challenging to assess frequency below 2 kHz. This slide presents a case of otitis media. The ABR showed 70 dB, while the bone conduction threshold measured by bone conduction ASSR were almost normal. The COR test showed 60 dB. This highlights the importance of differentiating between conductive and sensory neural hearing loss. In this case, the DPOA results were passed for both sides. The COR indicated severe hearing loss, and the ABR showed only the presence of wave 1 only. This is classified as auditory nerve disease. It's so-called auditory neuropathy, specifically Perthes-Meltzbacher disease. Here the causes the perinatal abnormalities that lead to NICU admissions. They include neonatal asphyxia, low birth weight, trauma, hyperbilirubinemia, and drug-related causes. Sorry. So, the outcomes of 2,272 cases with perinatal abnormalities are shown. It was found 55% of cases which are perinatal abnormalities, and hearing loss eventually improved, classified type B. So, sorry. Okay, sorry. The causes of frequency congenital hearing loss. But genetic, at birth, genetic is 68%, and non-genetic 32%. At age 4, genetic 61%, non-genetic 39%. Genetic problems is most popular is GJB2 mutation, 50%. And then non-SLC26A4, 5%. So this is the causes of congenital hearing loss. Inner ear anomaly, 25.6%. Genetic mutation, 21.8%. Cytomegalovirus abnormal, 15.7%. NICU abnormal, 23.1%. Auditory neuropathy, 5.7%. So inner ear anomaly, 152 cases. Details, stenosis of the cochlear nerve canal is most popular of inner ear anomaly. This is the CT findings. This is the stenosis of cochlear nerve canal. The opposite side is normal, but sagittal is narrow and the opposite side is normal. This is sagittal image of the internal auditory canal, MRI images. Facial nerve and cochlear nerve is hypoplasia. Superior vestibular nerve, inferior vestibular nerve. The opposite side is the normal MRI sagittal image of internal auditory canal. This is a changes in ABR 20 to 72 NICU cases. With perinatal abnormalities are shown, it finds that 55% cases with early perinatal abnormalities and hearing loss eventually improved, classified as type B. This slight improvement in hearing in NICU admissions is thought to be due to the maturation of the brainstem, which leads to the resolution of hearing loss. Regarding cytomegalovirus infection, approximately 90% of cases are asymptomatic. Testing is conducted using urine PCR, umbilical cord, and blood samples within 3 weeks of birth. Treatment involves the use of antiviral drugs. Currently, clinical trials for mRNA vaccines are being conducted worldwide, and development is progressing. In Japan, our institute also participated in the trials, nearly complete. Among those diagnosed with hearing loss through NHS, 70.9% tested positive for cytomegalovirus. This slide showed brain findings from CT and MR images of CMV cases. The primary findings include ventricular enlargement, classifications, cortical abnormalities, and white matter abnormalities. This slide presents an antibody detection rate for CMV. In Japan, the antibody rate detection was high, but it has been decreasing in recent years. Although the retention rate remains high in Asia and Africa, it is expected to decline in the future, indicating the need of preparation. Here, it is a case study. The patient is 8-year-old girl. She was referred to ENT department after hearing loss. Was detected at health check. Audiometry showed hearing loss in the right ear. But OA results were passed for both ears. Her parents were too busy to spend time with her, and she was overwhelmed with numerous extracurricular activities, such as ballet, piano, and drama, causing her stress. Based on her clinical course and test results, she was initially diagnosed with psychogenic hearing loss. She was referred to our institute to further examination. And ASSR revealed abnormalities. ABR also showed hearing loss in the right ear. This case was classified as auditory nerve disease. The experience reinforced the importance of conducting appropriate tests for children and not jumping to conclusion about the diagnosis. This slide outlines the characteristics of various hearing tests. Since hearing tests are challenging in infants, young children, and combination of COR, VRA, ABR, and ASSR is necessary. Additionally, cortical function tests such as NIRS should be performed, and attention should be paid to conditions like autism. It is challenging to test hearing differences between the left and right ears in children. Therefore, we perform separate hearing tests for each ear using insert earphones. This slide demonstrates the actual process of VRA test. Using insert earphone, VRA, a variation of COR, is based on conditioned search response. By diverting the child's attention with a visual stimuli, the child turns 90 degrees towards the sound, and the toy lights up using insert earphones for separate hearing tests for each ear. This slide shows the testing the VRA, bone conduction transducers. This slide presents the results of VRA test. Case 1. Case A is a 9-month-old with bilateral sensory neural hearing loss. Case B is 11 months with hydrocephalus and bilateral mixed hearing loss. Case C is a 9-month-old showing air condition thresholds and bilateral hearing aid threshold. Case D is a 2-year-old with ABR of 30 dB and VRA threshold match. In children, narrow ear canal increase response, making high frequencies. Sound pronounced when fitting hearing aids. High frequency gain is often reduced, but it is important to conduct real ear measurements considering RECD and ensure proper amplification for high frequencies. This slide shows the test using the needles to measure the response to sound stimuli at the cortical level. Near-infrared light, which is 1/3 the intensity of stimuli, applied to the head to examine neural activity, specifically, and hemoglobin concentration in blood flow. This test determines whether auditory stimuli activate the cortex. This slide presents a 14-day-old girl, which bilateral 60 dB hearing loss. She did not respond to a 70 dB air condition hearing aid. However, at 90 dB, blood flow increased, indicating response to sound stimuli. Bone conduction hearing aids showed an even greater increase in blood flow, clearly demonstrating brain activity. This slide's NIRS finding. Before and after cochlear implant, responses were confirmed but determining which sound stimuli are most effective remains a challenge for the future. This slide addresses the management of congenital hearing loss. Options include early intervention by a medical team, sign language, hearing aids, and cochlear implant. Pharmacological treatment include intravenous, drip, and intratympanic steroid targeting therapy, antiviral drugs, and gene therapy. This slide depicts the early intervention team. This slide shows in recently, we use the hearing aids use AI and can transcribe speech to text on a smartphone. Bone conduction hearing aids, such as BAHA, are also being used. This slide shows the number of cochlear implants in Japan. Currently, about 1,000 cases are performed annually, with children accounting for approximately half of these cases. The horizontal axis represents the timing of cochlear implant surgery, while the vertical axis shows the results of the PPVT. It's so-called Peabody Picture Vocabulary Test. The earlier the cochlear implant surgery is performed, the higher the PPVT scores. Before the 1 year, the PPVT score is the most high. So here is another case study. The patient is a 1-year-old boy, NHS, showed bilateral refer with no response in the left ear and 70 dB, in the right ear on ABR. At the first visit at 2 weeks old, urine PCR test performed revealing CMV positivity. There were no genetic mutation, and CT scan did not show any inner ear anomalies. Upon diagnosis, congenital cytomegalovirus infection, immediate intravenous antiviral treatment with ganciclovir was initiated. Urine is decreased and ABR is recovered. This is ABR findings before and after treatment. This is a treatment and hearing assessment. Hearing loss model, mice, 42 case. STT was first reported worldwide by Sakata 1999 as a treatment for tinnitus. Anesthetic was administered, abdominal cavity, and STT at a dose of 15 micrograms 3 times using a microscope. Currently, STT is frequently used clinically without anesthesia for sudden deafness, Meniere disease, and tinnitus. Anesthetic was demonstrated, abdominal cavity and ABR was performed. The results show hearing improves in the STT group. Improvement. But in the non-treated group, most cases showed no change or deterioration. This is a typical case of improvement. There was no change at 3 weeks. But in steroid STT treatment group, after 6, the waves appeared. In the non-treated group, waveforms present at 3 weeks disappeared. By 6 weeks, indicating the progression of hearing loss. So this is an 8-year-old girl with low birth weight was admitted to the NICU for 2 weeks. The NHS results wave passed for both years. She also had microcephaly, and CMV testing was positive. At age 8, she presented at our institute with hearing loss in the left ear. There were no other causes, such as a mumps, and she was diagnosed with sudden deafness due to late onset CMV infection. SCT was administered twice on the second and third days after onset. No CMV was detected in urine. Audiometry and DPOA showed improvement in hearing. This slide shows the treatment results of CMV in humans, our institute. Hearing assessment by ABR before and after vanganciclovir. Improvement total 21%. Gene therapy. In 2021, stem cells derived for human, iPS cells by Professor Yamanaka, were injected into the inner ear to treat GJB2 gene mutation. Pendred syndrome is also being treated using iPS cells. Additionally, for the OTOF gene, which causes auditory nerve disease, synaptopathy targeting inner ear hair cells, and the cochlear nerve is being developed. But gene therapy is just began our institute. So last slide, future challenges. In Japan, newborn hearing screen coverage is nearly 100%. The challenge now is how to resolve these records, monitor the progress of hearing loss, and adjust hearing aids. Although the causes of congenital hearing loss are mostly understood, about 20% remain unknown. And elucidating is crucial. Establishing a health mother-child relationship is also important. Accurately assessing hearing in children is challenging, especially differentiating between conductive and sensory neural hearing loss. Diagnosing at cortex level, including evaluating for autism spectrum tendencies, will be key. The treatment of congenital hearing loss is still its early stage. It is hoped the future treatment will effectively utilize drug development, gene therapy, antiviral agents, and steroids. Thank you for your kind attention.
Yes, the congenital hearing loss is so rare and so scarce around the world. But now you present a topic very difficult. Very good, yeah. So this is an interesting topic. Thank you, Professor Hideaki Sakata.